Hello, welcome to the EKG Guy and welcome to the EKG of the Week. I hope you're having a great week and I'm glad you could join us. So this week's case is a 48-year-old male that presents with a sore throat plus pleuritic and positional chest pain, and his presenting EKG is shown here. Now before we get started, let's review the approach we've been using to interpret EKGs. So notice we have the patient's clinical presentation and then the EKG below it. On the right side of the screen, you'll see a list that we'll go through before making our final interpretation. First, there's the regularity of the rhythm. That is, are we dealing with a regular or irregular rhythm? And then if it's irregular, we have to see if it's regularly irregular or an irregularly irregular rhythm. Next, we have the heart rate, and this is where we simply want to determine what is the rate of this rhythm we're dealing with. Then we have to look at the rhythm origin. That is, where's the rhythm actually originating from within the heart? And then we have to determine the ventricular or QRS axis, which could help us with our differential diagnosis. Then we have the atrial, atrioventricular, and intraventricular conduction, looking at if there's any conduction abnormalities in any area of the heart. And then we have the waveforms, which would include all the waves, segments, and intervals. And lastly, anything else, meaning is there anything else that we've missed or still need to mention, such as the abnormal R wave progression or an abnormal transitional zone in the precordial leads. Now, after we use all this and collect all the information that we've gathered, we're going to make a final interpretation of this EKG. Now, what I want you to do is pause the video, take a few minutes to go through it yourself. When you're ready, start the video and we'll go over it together. Okay, so we have a 48-year-old male that presents with sore throat plus pleuritic and positional chest pain in this EKG. Okay, so you don't have much of a history, but that's what you have to go off. So let's go through the EKG. Now first we said we have to check what is the regularity of this rhythm. Well, on first impression of the EKG, you probably notice that the rhythm appears quite irregular at places, but there is some regularity to it. So we call this a regularly irregular rhythm. Okay, so we'll just write this here. Okay, so this is regularly irregular. Okay, so IR will put for irregular. Okay, so regularly irregular. And why is that? Okay, so you probably notice what we mean by regularity is we want to look at what it's best to see is these R to R intervals. Okay, so from this R wave to this R wave, we call that the R to R interval. Okay, and then from this R wave to this one right here is another R to R interval. And notice that the distance between those, okay, this here and this are different. Okay, so it's already irregular. All right, that was that first part. And then we said we had to find out, is it irregularly irregular or regularly irregular? Okay, so we've said that it's regularly irregular, and that's because if you were to take these distances, okay, so this R to R interval, you'd see that it's the same as the one that follows. Okay, and then you'd see it's the same here. All right, and it's actually the same between this one, and this one. Okay, so you'd see that these are consistently the same R to R intervals. Okay, now what you would also see is that you'd have a consistent R to R interval with this distance. So from this R wave to this R wave, okay, from here to here, it would be the same as this first one. All right, and you would see it the same thing here. Okay, from this to this point, and then you would see it again from this R wave to this R wave. Okay, and notice that it's happening almost every third beat. We have one that's coming a little earlier than expected. So this is the first beat, second beat, okay, this is the second beat, and this is the third beat. So let me just erase that. So again, 1, 2, this is the third beat. Okay, notice that we have this beat is going to be the same distance than the one that follows. Okay, so this is that one there. All right, and if you were to go through, you would see that that's consistent throughout. Okay, so that third beat is pretty much coming sooner in each one of these. All right, and because of that, we call that, and you can start to see right there, a regularly irregular rhythm. Okay, so that's important to know. All right, so now let's move on to the heart rate. Well, this is an irregular rhythm, so we can simply count the ventricular complexes going across the EKG and then multiply that number by 6 because we know that the standard ECG represents 10 seconds. Okay, so let's just erase this, okay, so that this is clear. All right, and we're saying that the standard ECG, which you should know from the beginning all the way to the end, represents 10 seconds, okay? And if you multiply 10 seconds by 6, that's 60 seconds, which is the same thing as 1 minute, okay? So that means if you count the complexes going across, multiply by 6, you can get the beats per minute, or at least an estimate of it. So we'll do that now, okay? So here's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. Okay, we won't count that last one there. All right, so what we have here is 17 QRS complexes, okay, because we're going for that ventricular rate in this case. So 17 times 6, and what does that give you? All right, that should give you 102 beats per minute, okay? So we have a faster rate above 100 beats per minute, and the actual rate here on the ECG paper was 106 beats per minute, okay? So maybe if you included that last one, you would have got 108, all right? So pretty close, 106. So above 100 beats per minute, we're dealing with a faster rhythm. All right, so now let's look at the rhythm origin. Well, we have narrow QRS complexes, so it must be supraventricular in origin. That is, originating from above the ventricles. And we can also make out clear, defined, similar shaped P waves in each lead. So now we have to ask ourselves, are we dealing with sinus rhythm? Okay, so let's go over this now. All right, and when we talk about sinus rhythm, remember that when we look at this box diagram, okay, of our heart, this is the right atrium, the left atrium, right ventricle and left ventricle. The sinus node sits up here, okay, near that superior vena cava, all right? And from the sinus node, we have these internodal pathways that come to an AV node, as well as a Bachman bundle coming to the left side of the heart. We have the His bundle, the right bundle branch, as well as a left bundle branch that splits off into a left anterior and left posterior fascicle, okay? And both the right bundle branch and the left anterior and posterior fascicles then go to the ventricular Purkinje fibers that innervate the individual cardiomyocytes, okay? So when we talk about sinus rhythm, we're saying that it's coming from this area here, okay? That's where the rhythm is starting from. And notice that the conduction pathway is heading in this direction, okay? Meaning that if we were to put the right atrium over here, okay, so imagine this is the right atrium and we're putting our sinus node here, the conduction would head in this direction, okay? And the normal P wave axis, which represents atrial repolarization or depolarization, is between 0 degrees and positive 75 degrees, okay? The area in which that sinus node is, the impulse is moving, okay? So what we want to see with a sinus rhythm is upright P waves in leads 1 because it's heading in that direction. So lead 1, this is the positive end. This is lead AVF, so you can see them in there. Lead 2 sits at positive 60 degrees. In our horizontal plane, we have V4, V5, and V6. And then remember, AVR is over here, okay? So it's heading away from that, so you should see inverted or negatively deflected P waves in lead AVR, okay? So let's take a look at this here. We can see lead 1, which is here. So notice that we have these upright P waves, okay? And then we won't look at this third complex here, which we said is coming earlier, and we'll talk about that shortly. And then if you look at lead 2, the same thing. You have that. In lead AVF, you can sort of make them out right here, okay, in there as well. And then if we look at the left lateral precordial lead, so V4, V5, and V6 here. So notice that we have these upright P waves in each of these, okay? And notice that they all have the similar morphology, and you have one P wave before every QRS complex, okay? There's that 1-to-1 ratio, which is also required for sinus rhythm, okay? Now, what else did we mention? Well, we said that in AVR, which is here, remember it's over in this position, it's heading away from it, so we should see negative P waves in those leads, all right? So notice this is a negative P wave, and you have one there as well, okay? So we do have sinus rhythm in most of these beats, okay? All right, so sinus rhythm is present. Now, another thing we have to note here is that every third beat appears to be occurring sooner than expected with a P wave that actually has a different morphology than the sinus P waves that we just discussed. And this is best seen in lead V1, okay? We'll take a look at that. Now, the QRS complexes are narrow with these ones, so we know this is also a supraventricular beat, okay? So coming from above the ventricles, and we would refer to these as premature supraventricular complexes, okay? So meaning that it's coming from above the ventricles, so above here, okay? So what are we talking about? Well, it's this third beat. It's this one here that's coming sooner than expected, okay? And you can see it here in V1, okay, quite easily, all right? We can also see it down here in this rhythm strip, but notice how these P waves in the sinus rhythm are different from the ones that come with the premature beat, okay, meaning that it's originating from somewhere else and not from the sinus node. So those aren't sinus P waves, okay, and you can see that here. Here's a sinus P wave, and then the one that follows has a different morphology, okay, and then we go back to our sinus P wave, and then one that has a different morphology, but these both have the same ones, okay, and we said they're also coming sooner than expected, so they're premature beats, okay. So what we would call this, so we have the sinus origin for most of the beats, and then we also have another beat that's likely coming from somewhere in the atria or in the as a junctional rhythm or a junctional beat. So we're just going to simply call these premature supraventricular complexes, or you can call them beats, okay? And those are the third beat, and I just want you to see those, that not all the beats are coming from the sinus node, and those third beats are not, because they don't have that same morphology as our sinus P wave. So now let's move on to the ventricular or QRS axis. And you should have gotten a normal ventricular axis here. The actual axis is actually positive 1 degrees, so we'll just write that here. This is a normal ventricular axis and positive 1 degrees, okay? So let's look at how we find the ventricular axis, and we'll erase this to clear this all up. Okay, and do you remember which leads are the best ones to look for ventricular access? Okay, now there's multiple ways you can find it, and the one we'll use here is we'll first look at leads 1 and AVF. Okay, if those are sufficient, then we'll move to, then we won't need to go to lead 2, or you can simply look at leads 1 and 2, and that can help you get there as well. But we'll look at leads 1, which is here, and lead AVF first. So why do we look there? So remember that this is 0 degrees, okay? This is positive 90 degrees. This would be plus or minus 180 degrees, and then we have negative 90 degrees. Now normal axis, remember, lies between about negative 30 degrees and positive 105 or 110 degrees, meaning that all this here is normal axis, okay? And then we have a left axis shift, which would be in this region here. And this is more that pathological. This is what you sometimes hear as the physiologic leftward shift in this region here, but still considered normal in most adults. And then we have this extreme axis here, deviation, and then this is the rightward axis shift, right axis deviation. Okay, so we're going to look at leads 1 as well as lead AVF. So here's lead 1, the positive end, and lead AVF, it's positive end. So here's lead 1, we said. Notice that it's positive upright. Okay, so we have positive complexes in lead 1, meaning that we're going to head towards lead 1 in that direction. If we look at lead AVF, which is here, notice again we have these positive upright complexes throughout, okay? So we're going to head towards the positive end of lead AVF, okay? And notice that AVF is almost isoelectric, meaning that you have pretty much the same negative and positive components, okay? And that can help you know that the axis is likely perpendicular to AVF, so it might be running along this, okay? And if you look at lead 2, which would come right here at positive 60 degrees, that's the positive end of lead 2, it's positive and upright, heading in that direction, helping to confirm that we have a normal axis, and if it's isoelectric to AVF, then it's likely near 0 degrees. Now, what did we say the axis was? Well, we said it was positive 1 degrees, which is pretty much right there, okay? So this is a normal ventricular axis, and hopefully that makes sense. Now let's move on to atrial conduction. Well, typically we'll look at leads 2 and V1 for P wave or atrial abnormalities, as they appear to be the most evident in those leads. In leads 2 and V1, we don't reach the P wave amplitude for right atrial enlargement, but there may be some evidence here for left atrial enlargement, okay, in that terminal portion of the biphasic P wave seen in lead V1. The total duration of the P waves in leads 2 and V1 appear to be within normal limits, which is typically less than 120 milliseconds or 3 small boxes. Okay, so let's look at what we were saying by that possible left atrial enlargement. Okay, so let's look at this here. So the possible left atrial enlargement is this. Here's V1, okay, and you can see this terminal portion of these P waves, okay, And what we're seeing is that here's a biphasic P wave, so that's all of atrial depolarization. And why does the terminal portion represent the left atrial depolarization? Well, remember, with our box here, here's our right atrium. The sinus node is here, okay? And because it's in the right atrium, the right atrium will depolarize before the left atrium, okay? So it will depolarize first because the sinus node is located there, and then come over to depolarize the left atrium. Therefore, when you look at any P wave, the initial portion represents the right atrial depolarization, and that latter portion, which we see here, this terminal portion, represents left atrial depolarization. Now, when we're looking at left atrial enlargement in here, and you can actually see it's a little difficult to make out on the screen here, but if you had the EKG in hand, you would see that this is at least reaching 1 millimeter or 1 small box deep and at least 1 millimeter wide. Okay, so that may suggest possible left atrial enlargement, and we'll write that here. Okay, so possible left atrial enlargement by this voltage here. All right, so let's move on to AV, or atrioventricular conduction. In this case, we're looking for any conduction delays as the impulse travels between the atria and the ventricles, because the majority of the PR interval represents AV nodal conduction, and so we're going to look there. Now, normal PR interval in adults is between 120 and 200 milliseconds, or 3 to 5 small boxes. Now, in this case, it appears that the PR interval is within normal limits. In fact, it was measured to be 152 milliseconds, okay? So we have normal AV conduction. The PR interval here was 152 milliseconds, okay? So remember, the normal one is between 120 and 200 milliseconds, okay? So between the 3 to 5 small boxes. So we have a normal AV conduction in this case. Now let's look at the intraventricular, or IV conduction. In this case, we're looking at the duration of the QRS complexes. The normal QRS duration is often between 70 and 110 milliseconds, or 2 to 3 small boxes. Now, some may consider the upper limit to be 120 milliseconds. Anyways, the main thing we're checking for here with intraventricular conduction is whether or not the QRS interval is prolonged. On this ECG, we see narrow QRS complexes that appear within normal limits. In fact, the QRS duration here was averaged to be 100 milliseconds, so that helps to confirm that we are in fact dealing with normal intraventricular conduction. Okay, so we can write that in the average QRS interval, or duration here, was 100 milliseconds. Okay. How about the waveforms? Well, we already discussed the P waves, okay? There are no abnormal Q waves or QS complexes present. There are normal T waves that are asymmetric with a slow upstroke and steeper downslope. The PR segment appears to be depressed in some leads, like leads 1 AVL and maybe lead 2, and then in lead AVR, we seem to see some PR elevation, okay? So let's take a look at that. So what does that mean? So we said that there is, so remember, when we talk about the PR segment, this is our P wave, or QRS complex, and our T wave. The PR segment is from the end of the P wave to the beginning of our QRS complex. That's the PR segment, okay? The interval includes the beginning of the P wave up until the start of the QRS complex. Now, when we say that there's some PR segment depression, okay, we said that we saw those in the lateral limb leads. So here's lead 1. Somewhat in this one, okay, you can see that there. That might have blocked your view, but notice that some PR segment depression. Same thing in AVL, okay, slightly there, maybe more pronounced in lead 1. And we also said you may see some of that in lead 2, okay, maybe there and here, okay, so maybe some slight PR depression. Okay, it's hard to make out, but there does seem to be some there, and there is some PR elevation when you look at AVR. So here's AVR, okay, and notice the PR segment appears to be a little elevated there, okay, so that's something to note. Now, we mentioned the PR interval, okay, which we said was from the beginning of our P wave up until our QRS complex is normal, okay, it's less than that 200 milliseconds. The ST segment here actually appears to be diffusely elevated throughout the ECG with a concave morphology, especially in leads V2 through V6, along with leads 1 AVL and V2, okay, so let's look at that. So if you look at V2, V3, V4, V5, and V6, you notice that this ST segment here is diffusely elevated with that concave morphology in those leads, okay? Remember, the ST segment is from here to this point, And so the end of our QRS complex, which is our J point, okay, is the start of the ST segment. And we also saw some elevation in these lateral leads, somewhat here, okay. You can see in AVL the same thing there, and slightly elevated here in lead 2. Okay, so that's what we see there. And then if you look at AVR, you can actually see some ST depression. So let's erase that here. So AVR, we said that we saw some PR elevation, and you can also see some ST depression there. Okay. All right, so these are characteristic changes of something that we'll discuss shortly. All right, so we said the QRS interval was within normal limits. The QRS amplitude does not seem abnormally increased or decreased throughout the ECG. And lastly, the waveforms, the QTC interval is slightly prolonged here and actually calculated to be 480 milliseconds. Remember, normal QTC interval in males is less than 440 milliseconds. In females, it's less than 460 milliseconds. So overall, what we have here are the major waveform issues that we now have noted are these diffuse PR depression and ST elevation, along with PR elevation and ST depression in lead AVR. Okay. In addition, we noted that slightly prolonged QTC interval. So let's just add some of these here. Okay. The first thing we noted was that pretty diffuse, okay, PR depression and ST elevation. Okay, not seen in every lead, but you can see them quite a bit. Okay, especially the ST, the concave morphology that we saw in those precordial leads V2 through V6. The other thing to note here that we mentioned was the PR elevation. Okay, so in AVR we saw PR elevation. Okay, that's PRE, and ST depression. Okay, those are what we call reciprocal changes, the opposite changes of what we saw in the other leads. And then we also mentioned that slight prolonged QTC interval. Okay, so prolonged QTC. All right, so is there anything else we're missing here? Well, how about the R wave progression in the precordial leads? Now, normally the R wave amplitude should progressively increase from leads V1 through V5. In this case, it does seem like the R wave progression in the precordial leads is quite normal, so it's not a major concern here. Okay, so just so you're aware, we're saying that the R wave, okay, which is the first positive deflection after a P wave, should increase in amplitude from V1 up until V5 as we go from right to left across the precordium. So here's the R wave. Notice that it's getting slightly greater in amplitude as we go from V1 to V5. So we would consider this pretty normal R wave progression. Okay. So not too much of a concern. Now, how about the transitional zone in the precordial leads? Now, this ECG seems to appear between V5 and V6. The transitional zone is simply the precordial lead area where the QRS transitions from being mostly negative to mostly positive, with the actual transition area to be where the QRS complex is isoelectric. Now, normally the transition occurs between leads V3 and V4, so that's what we call a normal transition or transitional zone. If it occurs earlier than V3, then we call it a counterclockwise rotation or early transition, and if it's after lead V4, then we call that a clockwise rotation or late transition. Therefore, because the transition here occurs between V5 and V6, we call this a clockwise rotation or late transition. Okay, so we're saying that it's going from mostly negative to mostly positive between V5 and V6. Okay, so you can see in V4 it's still mostly negative. Notice from V1 it's mostly negative. V2, the QRS complex, again, still mostly negative. V3, the same thing. V4, the same thing. And then we get to V5, and it almost looks isoelectric, but if you were to count out those small boxes, it is still mostly negative in V5. And then when we get to V6, you can start to see that the R wave is greater than that S wave there, so it starts to get positive. So that transition is occurring between V4 or V5 and V6, okay? And because it's after V4, that's what we call this clockwise rotation or late transition, okay? So clockwise rotation or late transition, okay? All right. Now, one thing I want you to always keep in mind with R wave progression and the transitional zone in the precordial leads is that it's highly dependent on the lead placement of whoever's placing the leads. And again, this is an imperfect science. Okay, so make sure that you don't depend on them too much. Okay. Anyways, so what's our final interpretation? Well, we have a regularly irregular rhythm with sinus origin in most of those beats. We have some premature supraventricular complexes that appear to be coming at that third beat, and we have a rate of 106 beats per minute, so a faster rate. The ventricular axis we said was normal at positive 1 degrees. We have atrioventricular, and intraventricular conduction that appear to be normal. We notice pretty diffuse PR depression and ST elevation with a concave morphology, along with reciprocal PR elevation and ST depression in lead AVR. Now, these findings may suggest acute pericarditis in the clinical picture of the patient's sore throat, which may be a viral infection, as well as his pleuritic and positional chest pain increase the likelihood of this. Now, we also noted a slightly prolonged QTC interval and possible left atrial enlargement that we saw in lead V1. Now, unfortunately, there's no previous ECG to compare this to, so this is what we're left with, okay? So let's write some of our findings here, okay? So again, we have a sinus rhythm, a fast rhythm that's occurring at 106 beats per minute. So we call this sinus tachycardia, okay? And we also mentioned that we have these premature supraventricular complexes that we notice in those third beats. We also said that there's possible left atrial enlargement. So if you had an echocardiogram or an ultrasound of the heart, that may help to confirm that. Okay. The other thing we noted here was that diffuse PR depression in most of those leads that we saw in the ST elevation. And then in AVR, we saw some reciprocal changes of PR elevation and ST depression. Okay. And in that case, we said we cannot rule out acute pericarditis. Okay, and that's where the clinical picture of the patient helps out the most. All right, we said our patient has a sore throat and pleuritic and positional chest pain that may actually suggest acute pericarditis. Okay, and then we said that we had this slightly prolonged QTC interval. Okay, and that's that last finding we noticed. And when we said there's no other ECG to compare it to, this is all we have in this patient. Okay, so you may have recognized acute pericarditis from the clinical picture of the patient with this sore throat and the pleuritic and positional chest pain. Okay, and some of the characteristic ECG findings. Now let's briefly say a few things about acute pericarditis before we end here. Okay, so acute pericarditis is inflammation of the pericardium. Now, what are some of the causes? Well, infection, especially viral, is a very common cause. So this patient may have a viral infection or sore throat, may be a symptom of it. Rheumatoid arthritis, lupus, acute MI, post-MI, such as Dressler syndrome, can cause this. Radiation exposure, trauma, uremia, TB, neoplasms, post-cardiac surgery. Okay, so you can have hemorrhagic pericarditis that can cause this. Now, some of the clinical findings, as we saw here, were the positional chest pain. Inspiration and supine position tends to worsen it, whereas sitting upright and leaning forward tends to alleviate it. You can see an increase in the heart rate, as we saw with this patient, okay, above 100 beats per minute. They may have cold sweats, anxiety, a pericardial friction rub that you can hear. They may have an elevation in the troponins, as well as a pericardial effusion may be present on echo that may, if it progresses, become and lead to cardiac tamponade. Now, the typical EKG features that you see with acute pericarditis are static and slow changes that occur over days to weeks. So this is not like the MI where you have those dynamic fast changes occurring within hours. Okay, so the most common EKG features that you tend to see are generalized concave ST elevation. All right, it still tends to be less than 4 millimeters with or without a J-point notch, and also PR depression. Okay, and you'll also see reciprocal ST depression and PR elevation in AVR and sometimes in lead V1. Okay, and we saw that PR elevation and some of that ST depression here in lead AVR. Okay, now the general course that we tend to see is ST elevation that's followed by ST elevation that then resolves with T-wave flattening, and then we get T-wave inversion, and eventually we get the normal EKG that comes back. Okay, so again, this is something This is a static, slow changes over days to weeks, so it's not something that happening quite fast. And another common thing we can see with acute pericarditis is sinus tachycardia. Okay, oops, I just erased that, but it's that sinus tachycardia that we saw here. Okay, and just to fill that in for you, these were the premature supraventricular complexes. Okay, so sinus tachycardia is something very common that you can see with this inflammatory condition. Okay, so it's inflammation of the pericardium that's causing this, and it was the patient's clinical picture as well as these ECG findings, not fully diffused throughout, but the clinical picture helped to confirm this. Okay, so hopefully that makes sense. Now, in conclusion, our 48-year-old male that presents with a sore throat plus pleuritic and positional chest pain has an EKG showing sinus tachycardia, premature supraventricular complexes. We saw a prolonged QTc interval, possible left atrial enlargement, and findings that were compatible with acute pericarditis. Okay, and the clinical picture helped to confirm it, and that's what this patient had. Well, that's the end of this week's EKG of the week. I hope you learned something. Please don't forget to like this video and leave a comment below if you like what we're doing. In fact, many of you have asked how you can help us out. Really, the best way would be to simply subscribe and share this resource with your friends. You get free access to more than 300 videos. There's also a community of over 150,000 of us like-minded individuals on Facebook, so stop over and join the EKG Guy's Facebook community. If you need a crash course on EKGs, we launched our new EKG course. Check the link below if you're interested. The original cost is around $150, and I believe I made it less than $20 for a limited time. I may be biased, but after reading nearly every EKG textbook on the market, I think this is by far the best EKG series to take you from the beginner level to a physician level. I've even included our pediatric lectures. Anyways, check it out for yourself. I think you'll really enjoy it, and a number of medical schools and hospitals are beginning to use it. If you are a part of an institution, please contact us because we're giving a limited number of schools and hospitals free access to provide feedback and improve our course. And in that case, you can get the course for free. So leave a comment below and get in touch with us. And of course, check out our brand new website, ekg.md, the premier EKG resource for medical professionals, where you can find more lessons and practice. That is www.ekg.md. Last but certainly not least, your feedback is incredibly helpful, and your kind words are always an encouragement on those long days. So let us know how we're doing. Thank you again for your support. It is truly appreciated. We're the largest, fastest growing EKG resource in the world.